Hello, my name is John Kessler. I am a physician assistant student in the School of Allied Health at LSU Health Science Center in Shreveport. This presentation will be a discussion of essential hypertension as it pertains to the elderly. Hypertension is the most common medical condition encountered in the primary care setting today. Considered a pandemic, hypertension affects over 1 billion people worldwide, with half of those affected being individuals greater than 65, which according to the WHO defines the elderly age cutoff. Hypertension is the leading modifiable risk factor for the development of the world's top causes of death, to include the top two culprits, coronary artery disease and stroke, and also congestive heart failure and end-stage renal disease. What makes this alarming is that the development of coronary artery disease also contributes to CHF and/or end-stage renal disease. Development of any of these conditions, however, can have significant impact on quality of life and/or longevity of life. And since hypertension is non-selective in terms of race, as it affects all races, with African Americans being most affected, followed by non-Hispanic Caucasians, it is vitally important to keep hypertension well managed. The leading determinant in developing hypertension is simply getting older. As we age, our arteries have more time to develop atherosclerosis, which renders them being less resistant to the changes in pressure, and therefore needing higher pressure in order to supply distal tissues with the appropriate level of blood flow for adequate oxygenation. It was shown in the Framingham Heart Study, which is a longitudinal cohort study looking at cardiovascular risk factors and their impact on developing cardiovascular disease, that the lifetime risk for developing hypertension is around 90% as we age. Sadly, very little is known as to exactly why we develop hypertension in the first place. It's considered by experts to be a very complex interaction between heritable genetics, strong family history of hypertension, and variable environmental factors such as poor diet and sedentary lifestyle habits. Hypertension typically does not present with any signs or symptoms that will alarm the provider that their patient is currently hypertensive and in need of being managed. Termed the silent killer for this reason, it is characteristically insidious in its onset and kills due to its effects on virtually every organ system. The only trusted way to detect hypertension is simply through measuring your patient's blood pressure at every visit. Yes, I know, I slide with a lot of pictures and no words. But what these pictures are trying to say is that the examination of a patient with hypertension should be exhaustive. Hypertension affects the vast majority of organ systems, and in order to stay ahead of its destructive sequelae, providers must examine their patients thoroughly with a head-to-toe physical exam to include the eyes, looking for papilledema or signs of retinopathy such as cottonwool spots, brain, assessing for mental status and signs of weakness or neurological deficits, taking blood pressure in both arms, which can give clues into cardiac anomalies such as coarctation of the aorta, heart and lungs, feeling for heaves, thrills, listening for murmurs, clicks, gallops, or the presence of edema in the lungs, feeling the thyroid for enlargements or nodules, checking the kidneys for bruits to detect renal artery stenosis, and the vasculature to assess pulse symmetry, strength, and regularity. These labs and imaging studies are necessary to assess for secondary causes of hypertension and to gauge the overall state of health for the organ systems most affected by hypertension. Check your CBC, might find polycythemia, CMPs, look for electrolyte abnormalities, get plasma metanephrines if you're considering pheochromocytomas, TSH and free T4s for hyperthyroidism, BUN and creatinine, check for acute and chronic kidney injury states, get renin levels to evaluate for potential renal artery stenosis, get a urinalysis, especially if the patient is pregnant, to detect proteinuria in the case of preeclampsia. Also detects hematuria for other evidence of possible glomerular injury. 12-lead EKG will show disturbances like AFib or cardiovascular muscular imbalances such as left ventricular hypertrophy. Chest x-rays looking for cardiomegaly or pulmonary edema. Echocardiograms for further evaluation of the 12-lead findings and to assess ejection fraction. Get a renal angiogram for evaluating renal artery stenosis, or a CT angiogram which would detect an aortic aneurysm or aortic coarctation. The United States Preventive Service Task Force recommends that hypertension be diagnosed at 3 separate elevated blood pressure measurements are made over the course of 3 healthcare appointments. JNC8 recommends treatment begins after the patient's blood pressure is above 150/90 if there are no accompanying conditions such as diabetes or chronic kidney disease, and above 140/90 if there is accompanying diabetes or chronic kidney disease. There is, however, new research coming to light from the SPRINT trial, which is still underway, but released early results showing significant benefit mortality if blood pressure is kept below that of 120 systolic. It'll be interesting to see if these findings change the current guidelines going forward. With respect to what we as providers have in our arsenal to treat our patients with hypertension, the most important to get right is adherence to lifestyle modifications. It is vitally important to stress that patients who lose weight, reduce their dietary intake of sodium, and increase their intake of fruits and vegetables, exercise at least 5 times a week and at no less than 30 minutes per occurrence, and stop drinking and smoking show greater reductions in their blood pressure measurements than those with just pharmacological means alone. But for those patients whose hypertension is difficult to treat and lifestyle modifications just aren't cutting it, this is where pharmacological means come into play. For those who have no issues with diabetes mellitus or chronic kidney disease and are right, any one of the 4 drug classes can be employed. However, those who are black should be started on either a thiazide or calcium channel blocker, as this race class does not respond well to ACE inhibitors or ARBs, as well as their white counterparts. If a patient has diabetes mellitus or chronic kidney disease, then an ACE inhibitor or ARB is crucial in preventing further kidney disease regardless of race. It should be noted, however, that it is important to get a BUN and creatinine for prescribing thiazide diuretics, as they are not effective in chronic kidney disease states. Thank you for the opportunity to discuss this important topic with you. Listed are my references used for making this presentation.